Welcome. Today we're doing a deep dive into perforator flaps, really focusing on the core definitions, the classifications, and the key surgical points you need to have clear.
Exactly. Let's start with the basics. So a perforator flap, it's essentially skin and subcutaneous tissue, right? But its blood supply comes from these specific perforating vessels.
Okay.
These vessels start deep from a source artery below the deep fascia, and they travel up to supply the subdermal plexus, the skin,
hmm
the whole territory, the perforosum.
Right, the perforosum. And you mentioned direct and indirect perforators. What's the key difference there, practically speaking?
Okay, so a direct perforator is, well, direct. It comes off the source artery and punches straight through the deep fascia, no detours through muscle or anything else deep.
And these can be cutaneous or septocutaneous.
Precisely. Direct cutaneous goes straight to the skin. Septocutaneous travels within an intramuscular septum before reaching the fascia.
Got it. And indirect.
Indirect perforators take a route through some other tissue first. Most commonly, that's muscle, the musculocutaneous or myocutaneous type.
That's the classic one we think of.
It is. But they can also pass through nerve, vein, bone, periosteum, tendon, even glands before they cross the deep fascia.
So surgically, what does that mean for dissection with indirect perforators?
Well, the goal is to free up that perforator vessel from the tissue it's passing through. This can be tricky.
Uh-huh.
You risk injuring the vessel itself, which could compromise the flap. The blood supply might be more tenuous sometimes. Plus, you could potentially damage or defunctionalize that intermediate tissue, like the muscle.
And potentially more scarring or a bulkier flap if you had to take some muscle with it.
Exactly. There's definitely more potential complexity. There was some historical debate about what counts as a true perforator, but, both types are clinically very relevant now.
Okay. How do these perforator flaps fit in with, say, fasciocutaneous flaps? They seem related.
They are closely related. Traditionally, fasciocutaneous flaps always included the deep fascia, the idea being that the fascial plexus added vascular reliability.
But that idea has been questioned.
Yes, whether including the fascia itself is strictly necessary. Fundamentally, both types rely on perforators coming from deep source vessels below that fascia. Think Mathesnahi classification types A, B, C cover these patterns.
So including or excluding the fascia changes the name.
Essentially, yes. Take the radial forearm flap. You can raise it with the fasciocutaneous flap, or you can raise just the skin and fat on the same perforators, leaving the fascia down. That's a perforator flap.
And the dissection differs.
Right. In a traditional fasciocutaneous flap, you usually take the fascia and the overlying adipocutaneous tissue together as one unit. In a perforator flap dissection, you're specifically isolating the perforator and taking only the necessary tissue, often separating it from the fascia.
Which means you might not know the exact perforator details in a standard fasciocutaneous flap harvest.
Potentially, yes, it's less selective. It's similar for myocutaneous flaps versus myocutaneous perforator flaps. Same source vessels, but with the perforator flap, like converting a tram to a dike, you dissect out the intramuscular perforators specifically to spare the muscle.
Right, preserving function. Okay, let's talk angiosomes and perforosums. How do these concepts help us plan?
Good question. So Taylor described the angiosome concept, basically, a 3D block of tissue supplied by all the perforators coming off one source artery.
The whole territory for that artery.
Correct. The perforasum idea refines this. We now know there are over 300 individual perforators identified, and each one supplies its own 3D vascular territory that's the perforosum.
Ah, so much more granular.
Exactly. It means you can potentially design a custom flap based on just one reliable perforator. And these individual perforasums, they're connected to their neighbors by linking vessels, a bit like choke vessels between angiosomes.
Providing some backup supply.
Right. So multiple perforasums linked together make up the angiosome of that main source vessel.
Okay, that makes sense. Now, classification. You mentioned historical debate. Is there a standard system now?
Not quite a single universal one, unfortunately. But the Gent consensus and the Canadian systems are probably the most widely adopted. Others have been proposed too, like American and Korean systems.
So what's the gist of the Gent consensus?
Gent names the flap after the nutrient source vessel. Simple example. DIEP flap, from the deep inferior epigastric artery perforators.
Okay.
If one source vessel supplies different potential flaps, they might add the muscle involved, like TFLP for tensor fascia lata perforator, or the anatomical region, like ALTP for anterolateral side perforator.
And the Canadian system, how does that differ?
The Canadian system also starts with the source vessel, but they typically add artery to the name, so DIEA flap for deep inferior epigastric artery perforator.
All right.
They also use abbreviations for the muscle, like LCFAP, FLL, for a lateral circumflex femoral artery perforator flap, based on perforators through the vastus lateralis muscle. And they use S to denote septocutaneous types, like SFAPs for a sural flap artery perforator, septocutaneous type.
It gets quite specific. What about freestyle flaps?
Ah, yes. Freestyle perforator flaps are usually local regional adipocutaneous flaps. You basically identify a suitable perforator preoperatively, often with Doppler near the defect, and design the flap around it. Propeller flaps are a common example.
So based purely on the perforator, you find.
Exactly. Its location and quality relative to the defect are paramount. The GENT consensus generally recommends naming even these based on the nutrient vessel if it can be identified.
Makes sense. So moving into practice, which perforator flaps are the real workhorses?
Well, they become mainstream now, definitely for both free tissue transfer and local flaps. In terms of frequency, based on donor site popularity, the DIEP flap and the anterolateral thigh, or ALT flap, are right up there.
Let's talk ALT first. Key features.
Okay, the ALT. Its main blood supply comes from the descending branch of the lateral circumflex femoral artery that gives mostly musculocutaneous perforators through vastus lateralis, but sometimes septocutaneous ones too. The transverse branch can contribute, but usually smaller myocutaneous perforators.
And classification.
Gent calls it ALTP. Canadian would be LCF8PVL for vastus lateralis perforators, or LCFTs if septal. Mathis and Nahe types A and B cover the vascular patterns.
Advantages. Why is it so popular?
Several reasons. The donor site usually closes well. Dissection is relatively straightforward most of the time. You get a good long pedicle. And it's incredibly versatile. You can tailor the size, make it sensory, use it as a flow-through flap, even include some vastus lateralis muscle for bulk if needed.
Versatile is good. Any downsides?
The donor site scar can sometimes be unsightly depending on the patient and the size of the flap. And in obese patients, dissection can be more challenging, the fat thickness is variable, and intramuscular dissection can be tougher.
And uses.
Widely used. Locally for groin, trunk, ischium, abdomen, lower thigh, knee reconstructions, often as propeller or reverse flow flaps. And as a free flap, it goes pretty much everywhere. Head and neck, limbs, trunk.
A true workhorse. Okay, what about the DIEP flap?
The DIP flap. This relies on musculocutaneous perforators coming off the deep inferior epigastric artery traveling through the rectus abdominis muscle.
Classification.
Gent DIEP flap. Canadian DIEAP flap.
And its advantages.
Yeah.
Especially compared to, say, a tram flap.
The big one is preserving the rectus muscle and the anterior rectus sheath, which reduces donor site morbidity like hernias and weakness. You still get a good volume of tissue, a long pedicle, plus you have the contralateral side as a backup. You can even convert it to a muscle-sparing tram if the perforator dissection is too difficult. And there's potential for supercharging if needed, maybe using the SIEA system.
Sounds good, but what are the challenges? It has a reputation for being technically demanding.
It definitely does. There's significant anatomical variation in where those perforators are, how many there are, and their course through the muscle. They can run through tendinous inscriptions, which makes dissection harder.
Right.
Selecting the right perforator or perforators is absolutely crucial. Picking a poor one can lead to partial or total flap loss. Venous congestion can also be an issue if the connections between the deep and superficial venous systems aren't adequate.
So careful pre-op planning and meticulous dissection are key. Where is it most commonly used?
Locoregionally, it can cover defects on the abdomen, genitals, groin, sometimes the buttocks. But its main use, overwhelmingly, is free tissue transfer for breast reconstruction. It can be used elsewhere, but the sheer bulk might be too much for some defects.
Okay, so to wrap up, what are the absolute key takeaways for someone needing to understand perforator flaps?
All right, main points. 1, perforator flaps are a standard mainstream option now in reconstruction. 2, the nomenclature and classification are still a bit messy, let's say. There's ongoing debate.
But understanding that debate helps understand the anatomy.
Exactly. Understanding the history and the different systems helps you grasp the anatomical principles. 3, remember that most of the common perforator flaps we use, like DIEP and ALT, are based on indirect perforators, usually musculocutaneous ones.
And they offer advantages over older flap types.
Generally, yes. Because you're often sparing muscle, they tend to be sleeker, more pliable than traditional myocutaneous flaps, better donor site, often. And finally, number 4, Success hinges on choosing the right perforator, its quality, its size, how many you take, and exactly where it's located relative to the defect you need to fill.
So really understanding these fundamentals, the definitions, the vascular concepts like perforescence, the classifications, and the principles of perforator selection, it's absolutely crucial for contemporary reconstructive surgery.
Couldn't agree more. It's the foundation for using these powerful techniques effectively.
And it's clear this field is still evolving, constantly being refined, which ultimately pushes us towards better and better reconstructive outcomes for patients.